YouTube, what's going on? It's your boy, back at it. If you watched my previous video, at the end of the video, I said that I would, give y'all more information on what a IABP is. That's an intra-aortic balloon pump. That's what this is right here. Okay, this is the console that we use for the balloon pump. Now you say a balloon pump, you thinking of an actual balloon. Why do you call it a balloon pump? Well, I'm going to show you the catheter. As soon as I untangle all of this stuff, I'll show you this catheter. A balloon pump is a catheter, right? This is it. This is the catheter. This is the balloon pump catheter, right? This is the actual balloon. This balloon, it inflates and deflates. Inflates and deflates, okay? You probably think, okay, why would you need a balloon? What kind of person needs a balloon? Well, people whose, to make it simple, hearts are sick. To dive deeper into that, patients who had cardiogenic shock, patients who had myocardial infarction, or patients who had LV failure. Now, it depends on how severe the LV failure is. When I say LV, I mean the left ventricle. If it's too severe, then a balloon pump is not going to really help that case. You're going to need something stronger that produces more blood. But for some cases, it will help. For coming off bypass, if a patient is having a cabbage, like I was in the other day, they're coming off surgery, and they may need support to help them come off, then a balloon pump will assist. For PCI cases, those are cases in the cath lab. High-risk PCIs, regular PCIs, a balloon pump can assist, all right? So for you normal people out there who just saying, okay, in what condition would I have where I would need a balloon pump? Well, when your heart is having problems, and let's say you are you're having shortness of breath, or you're noticing different palpitations in your heart. You know, your heart has a rhythm, and so now your heart is getting off rhythm. It's being disrupted. You're noticing you're getting dizzy, or anything that is abnormal in regards to what's going on with your heart. Those could be causes and conditions that may imply that you could use a balloon pump, or you may need a balloon pump. If medication is not working, if resting, is not working, then they have to take it to drastic measures, and so you would need to be scheduled in the cath lab, or even bedside, or in the OR to have a balloon pump. Okay. So, like I said, the balloon pump, what it does is it inflates and deflates. This is the actual balloon pump right here. This is material, polyurethane. This is inserted in your femoral artery, right? This is your femoral artery. These two, all right? They go through the femoral artery, most of the time through a sheet, sometimes sheetless, but most of the time through a sheet, through the iliacs, and it goes all the way up into your aorta artery, and it stops at the aortic arch, right below the subclavian, okay? And so what it does is, when your heart, your heart contracts, boom, 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 boom. So when your heart contracts, the heart is sending blood to the rest of your body. Now you're probably thinking, how's it gonna send blood and it has this catheter inside of it blocking its way? Well, the catheter is not gonna block it, because when the heart contracts and it sends blood, this balloon deflates, right? When the heart relaxes, then this balloon inflates. And what it's doing is it's pushing blood back into the heart. Why? Because your heart is weak, okay? And if you have myocardial infarction, the balloon is trying to improve the oxygen demand. It's trying to improve the load, well, take the load off of your heart that is pretty much, causing your heart to weaken like it is. And so, like I said, once it's relaxed, this thing inflates, pushing blood back into your heart, perfusing your renal arteries, all right, your renals, and then it perfuses the rest of the body. Once it contracts again, then this deflates, pushes blood into the body. And so it's two things that's happening. It's increasing your blood pressure perfusion. It's reducing afterload, and it's reducing the workload that's on your heart. So the balloon pressure should increase cardiac output and help you if you was having symptoms of shortness of breath and all those things, conditions that I named earlier. Then this balloon is going to help you with that. Okay. Now the balloon can be placed femoral or through axillary. Axillary, it comes through the subclavian. Okay. And so when it goes through the subclavian, it's the same premise. It's going to inflate and deflate, except it's now positioned opposite. So the tip of the balloon is towards the renal arteries, right above the renal arteries, and the end of the balloon is right below the subclavian. So still the same process: inflates, deflates, contracts, it deflates. When the heart relaxes, it inflates. Okay. The reason why we would put it in this way is this gives patients the option to be more mobile. And I'm not gonna say more mobile. They can be mobile. They can go and walk around. They can move around. This way does not allow for a patient to walk or to be mobile because they cannot move their leg. Okay, you have this artery in your leg, you cannot move it. A lot of patients have to be restrained because, just human nature, we're used to moving around. But you move it, you could change the position of the catheter, you can kink something off, a lot of things can happen. And so putting it in this way, especially for patients who are in the hospital for long periods of time, waiting on transplants, waiting to see, hey, what's the next step, just waiting to recover. This is the better practice. That way a patient just is not bedridden. They're not just laying in their bed, waiting on what's the next move, developing bed sores, muscles not being worked, all that type of stuff. Now, most centers, or a lot of centers will place balloons in this position. Like I say, it's just a better thing. All right. Now, getting back to the catheter. So, this catheter, it comes in 3 different kits. Okay. We have 34 cc. Okay. 40 cc. 50 cc. Okay, so that lets you know cc's meaning how much this balloon fills. Those different sizes. Of course, the smaller the size, the larger. The smaller the size, the smaller the balloon. The larger the size, the larger the balloon. Okay, smaller sizes are for smaller patients. 34 cc's are typically for patients, 5 foot to 5'4", or even just, I'm gonna say 5'4" and under. Okay. The 40 cc's are for patients 5'4" and over, while the 50 cc's are still for patients 5'4" older. I mean, not 5'4" older, 5'4" and taller or larger, but they displace more blood flow because they're a little larger in size, and they're the most updated catheters, meaning they're opposed to being sensations, they're sensation plus. So their diameter that they inflate is a little larger, and it gives out a little more cardiac output than what the sensations do, okay? And so here at the hospital, we use all three, okay? There used to be a 25 cc, which was pediatrics, but I think most physicians and clinicians just started using 34s because it kind of had the same results, right? So this one right here, this is a 40 cc. Maybe I can't see that. No, 40 cc, 7 French. So like I said, these balloons, they have to go through a sheet. Now, they do have sheetless insertions that you can do, but most of the time they're gonna go through a sheet, okay? And for a 40 cc, physicians can use a 7 French sheet, or they can use an 8 French sheet. For a 50 cc, physicians will use a 8 French sheet or a 9 French sheet, okay? And so the sheet is just what it passes through, okay? And so before it passes through the sheet, I don't think I have a sheet. Anyway, the sheet is placed femorally, okay? First, we have to make an incision. They make an incision through the femoral, then they get a wire, okay? With that wire, they'll put in a sheet that passes over it, okay? Once the sheet is placed, then that same wire, which is usually a 018 off of sensation plus, is a 025. Then that wire stays in. Let me see, then you'll go up. You'll place that wire through. There's a little hole at this sensor, fiber optic sensor tip. Place it. And that wire is going to feed all the way through here and come out through this little port right here, this little transducer port, okay? Now, this is going to be a one-man job or a two-man job. I mean, 2-man would be better, more effective. And so the wire is the guide wire. It's just guiding it all the way up. Guiding all the way up to second or third intercostal space. Once you look at the imaging, and you see that the balloon is placed correctly, through this little port right here, we'll take the wire out. Okay. Then this port will connect to a transducer. Well, it may connect to a transducer, or it may connect to a 3-way stopcock, which connect to a cap, just to cap it off. You can, nurses can draw blood from here. If for some reason we needed to transduce, you can transduce from here also, okay? All right, so once that's that's how the balloon is inserted into the body, okay? Now this orange cable right here, this orange cable is called the fiber optic cable. The fiber optic cable is a pressure cable. Basically, it's like a sensor inside of here. And this right here is the tip. This is the sensor tip that is sending fiber optic. Since it's sending fiber optic, just little components to the actual balloon console. So this is going to plug right into the back of here. Okay. Once that is plugged into the back of the console, you'll see on your monitor, and it's not on, I'll turn on in a minute, you'll see a pressure waveform start to appear. That's how we know that, okay, the catheter is inside the aorta, all right? And so the fiber optic cable is present, it's working, it's functional. We know that because we can see the waveform, okay? And so this allows us to have our own balloon pressure. A lot of times in ICUs, CCUs, they'll have their own arterial pressures, arterial, radial, cuff pressures, whatever. The balloon has its own pressure that it's sensing from the tip of the balloon in the aorta. And those, most of the time, those pressures correlate with the arterial pressures, with the radial pressures, you know. And so once that's set up and we're wherever we're at, bedside, cath lab, OR, all those type of things, then we can go on, okay? And so that's that. Now let me show you let me give you a live look how this, you know, looks when turned on and pumping and running, okay? Oh, so this right here, this is the extension tube, okay? So before I can initiate this balloon pump, we have to connect the extension tubing to the catheter. Forgive me if I'm kind of all over the place. And then this male end of the tubing is going to connect to the back of the console to the female port. And you can just give it a little twist so it can stay in. And this is going to deliver helium to the balloon catheter to allow inflating and deflating. Okay? Very simple. Very simple. Okay, so this is the screen you see. Now, this isn't normally how it would look. The reason being, you will have an EKG there. And so the balloon has to have something to trigger off of. It has to. If there wasn't an EKG, we would have a pressure. This balloon isn't inside of a body, so there's no pressure. So that means I'm going to simulate with my little simulator an EKG and a pressure. See how much I like y'all? Give me y'all access. Give me y'all instant. Give me y'all sneak peeks and full access of how we get down here. All right, so got that connected. I forgot one thing. Make sure y'all can see. Make sure y'all getting a good look of everything. There we go. There we go. right here. I just want y'all to see the balloon inflate and deflate. So we have a pretty normal EKG. You see we have the fiber optic waveform. We are set. So what I would do, I'll go to my screen. Let me bring y'all closer. So I'm gonna go to my screen and I'm gonna make sure this is all the way to the max because I want full inflation. If this isn't maxed out, then it's not gonna inflate fully. Depending on what you have it on, that's how it's gonna inflate. So if you have it halfway, then it's gonna a minimal. You want full inflation, full deflation, you gotta put it on max. I'm gonna go make sure we at 1-to-1. If that's what the physician wants, we're gonna go 1-to-1. Pressure is direct, meaning it's directly coming from the balloon. It's fiber optic. It's not arterial. It's not radial. If it was, then this would be external. That means I would be taking the pressure from a radial line or arterial line and transferring it onto the balloon. But it's fiber optic, meaning it's coming directly from the balloon catheter. Okay. You see we have a EKG of 80. A heart rate of 80. EKG is normal. Okay. And my trigger is grayed out, but it's set to EKG. EKG is always the default trigger that we use. Okay. Auto is pretty much letting the computer automatically choose what's the best trigger timing for the balloon. Okay, because one thing about the balloon has to inflate and deflate on time because, like I said, it's counterpulsation in regards to the rhythm of the heart. So when the heart rate relaxes, the balloon has to inflate. When the heart rate ejects, the balloon has to deflate. So your rhythm and your timing of your balloon has to be correct. And auto does that for you. Okay, they do that for you. If it gets a little tricky for auto, then we have semi-auto, which gives you some type of semi-control. Still, auto will do some things to help, but it gives you a semi-control where you can control timing, meaning inflation and deflation of the balloon pump. Okay, but auto is always it's the best thing to go. Okay, now we're ready to start the balloon. I'm just gonna put that right there, and we're gonna hit start. So the balloon has to go through an auto-filling process first. Okay, and that's coming from here. So a piston here. Okay, gives it a little push. Then it has to zero pressure. Up. There it goes. So now we're zeroing pressure. It's zeroing because now we want to get a pressure for our fiber optic cable. So let it zero. And up, we got a pressure now. Up, look at that. Okay. Now, if this balloon gives, it's an old balloon. Like this catheter is old, so it's not the best use. There might be some, the quirks in it, but for the most part, you see how the balloon is inflated. And so, this is what the balloon does. Put somewhere where you can see it's transparent. This is what this balloon is doing inside of your aorta. It's doing this in your body. There's a little balloon jumping around like in your body, helping your heart, taking some of the demand off the heart, increasing myocardial oxygen demand, increasing perfusion. This little thing right here. Okay. see our numbers. Numbers look good. This is the ideal balloon waveform. Yeah, so we have our balloon pressure. Now this right here represents unassisted, meaning that will be the patient's pressure without the balloon helping, okay? Assisting, meaning the balloon is helping, it gives us this augmentation pressure. So this is the true systolic pressure when the balloon is helping. This is the unassisted systolic pressure when the balloon is not helping. You see the improvement? This was 96 without the balloon, 111 with the balloon. You feeling great now. You are feeling great. Okay? And so we can, like I said, change pressures if we need to. I mean, well, not change pressures. Change the trigger to pressure. Let's go to pressure. Let's say something's going on with the EKG. He's like, I don't like that. I'm gonna go to pressure. I'll go there, okay? Now, if we had a pacemaker in place in our EKG, then we can use one of the pacer triggers. And so we have a lot of patients who have pacemakers. And sometimes the pacer throws off the balloon inflation and deflation. It just throws out the balloon. So we have to go to pacer and to get a better trigger to get our balloon to inflate and deflate and perform better, right? Internal, we would use internal if the patient is coding. Let's say the patient is, they're performing CPR and the patient has no trigger at all, right? There's no trigger. Pressures are very low blood pressures, but we need balloon support. We can go to internal, and internal will allow us to set the rate, the heart rate, and the balloon will trigger while they're doing CPR, okay? I told you about pressure. If for some reason we didn't have a fiber optic pressure, we could take the arterial pressure from the monitor in our room, in our CCU, in our OR, in our cath lab, and we could use their pressure to display on our monitor. We have the ratios of 1:1, 1:2, 1:3. We would go 1:2. A lot of times I see that when they're trying to wean a patient off balloon. When they feel like, hey, this patient is recovering, they're doing well, let's go to 1 or 2 and just monitor them over the next few hours, and that will indicate if we want to take the patient off. Or if a patient has another assist device, let's say a patient has an ECMO, a patient has an LVAD, something of that nature. Well, since the assist device is already assisting in generating blood flow and pretty much doing what it does, being a mechanical circulatory device, well, you don't want to overload, so we would place the patient maybe on a 1 or 2, where it inflates and deflates on every other heartbeat. Or we would place it on 1 to 3. Okay, and so that's that. This is our timing. If for some reason we needed to inflate sooner, you'll see the adjustment happen, right? You always want to inflate at the diacritic notch. If we need to deflate, This is deflation marker. We can deflate later. You see the change? Or we can deflate sooner. Watch the waveform. Watch how it changes. Watch the waveform. See that? See how that is much sharper? But that's a very late deflation. If timing isn't in your thing, put it on auto. Let it automatically do that for you. It'll take care of it. Okay. This balloon is just gonna keep going. This is what it's doing inside the body. Pump, 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 pump. Okay. So this is our console. We have EKG cables. These cables are cables that we use to connect to the monitors when they're in the ICU, CCU, cath lab, OR, where we can, instead of applying our own EKG, we can take the EKG from the bedside and place it on our monitor. If we want to apply our own EKG, then we have our own EKG cables for that also. This is our EKG cables, which we place. This balloon has helium. Our helium tank is down here. The helium lasts for a long time. When I say a long time, I mean possibly a couple of months. We check it when we do rounds. As you can see, this one's pretty much full. It's in the green, so we good. Okay. The balloon consoles also come with Dopplers. So, you know, nurses can check what they need to check with the Doppler. Sometimes they be stealing my Dopplers. I'm not gonna say nurses, but I come across a couple consoles and my Doppler was missing. Cut it off. See, this is connected. It's supposed to be connected here. I've seen to where it's cut off. Doppler gone. Doppler gangers. Here we just keep things like stat locks. This secures the balloon after it's placed. And we have our transducer cable. Use this to transduce if our fiber optic cable is no longer functional. Those wheels. It's our extended tubing. We have to have extended tubing. We have to have the extended tubing. And this extended tube is about 7 feet long. Balloon console comes with 2 lithium-ion batteries. We can check how much power. Fully charged. Yep, there we go, fully charged. Got our vent system. We had somebody blocked this, and so our balloon was just going off. It was like temperature error. Well, we looked. They had blankets and stuff blocking the vents, so it was overheating. You have to let these machines cool down. Like they put in a lot of work, so don't ever block this. EKG pressure. If we want to send our fiber optic pressure to bedside CCU monitor or CV or OR, we have a cable that we can do that. This is external. We can, like I say, plug in their, we can receive their EKG or pressure with these cables. This right here. This is the Mach-Loop stuff. Fiber optic. Yeah, that's that, man. All right, man. So yeah, that was a brief lesson for our balloon pump, our intra-aortic balloon pump. This is a device that we use very often, very often. I want to say daily. We use a balloon pump. But like I say, they can be inserted. They can be inserted cath lab, OR, bedside. Pretty simple insertion. You know what? Let me not say that because I'm not a doctor. I'm not a physician. But balloon pump is one of the first things that they teach fellows, and so it's a go-to. It's a great product. It was, you know, man, cutting edge technology when it first came out, and it's still a go-to today. Like, this came out years ago. Like, I don't know the exact date, but I think like maybe in the 90s, maybe 80s. Still. All right.